Hi, everyone. Welcome to the Unison Community Podcast. I'm the host and founder of Unison, Gabriella Newell. We hope you'll continue the conversation with us at unisoncommunity.com. Hi, everyone. Welcome to today's episode. Today we have Dr. Kalee Woody with us, and she practices perinatal psychiatry in Oklahoma City. She completed her general psychiatry residency at the University of Missouri-Columbia and her perinatal mental health certification through Postpartum Support International. She recently started her first psychiatric clinic in the state of Oklahoma with a sole focus on diagnosis and treatment of psychiatric disorders during pregnancy and the postpartum period. Her goal is to educate women on the risks of untreated mental health illness during pregnancy. So thank you so much for being here today, Kalee.
Yes, thank you so much for having me. This is so exciting.
I just want to get right into it. So we said a lot of very technical terms in your introduction. So maybe we can start by just breaking those down a little bit for our listeners. So from your perspective, how would you define the field of perinatal psychiatry?
So perinatal psychiatry is just a term for taking care of mental health during the pregnancy period and up to 12 months postpartum. That's really all it means.
So another question that I had for you is the term postpartum. This term flies around a lot online and in the media, and I think we have a better awareness of it now, luckily, which is great. Just women in general understanding postpartum at a high level. But could you define postpartum for us? Is there a specific time period that the postpartum period is? Is it that 12 months?
Yeah, so postpartum in itself just means after birth. Some specialties consider postpartum like 6 to 8 weeks. So for example, your OBGYN after you give birth will have like a 6-week follow-up, and then they won't see you again until you have a well woman exam or if you're having another child. But in the field of psychiatry, a broader term for women's mental health, the focus is reproductive psychiatry, and perinatal is just a subset in that. But within reproductive and perinatal psychiatry, we consider up to 12 months to be postpartum.
Okay, got it. That makes a lot of sense. So then, if a woman who is pregnant or looking to get pregnant, should she be seeking a psychiatrist automatically, or who needs a perinatal psychiatrist?
So, I have seen women and birthing people who have come in just kind of curious about their chance of developing postpartum depression and postpartum psychosis. And some of these women are just curious about what they've read online, what they've seen, and they're actually scared to get pregnant or scared, they're scared that they have a chance of getting one of these illnesses and they have actually no psychiatric history. That's totally fine. You absolutely can come in for an appointment with a perinatal or reproductive psychiatrist. That'd generally be like a one-time consultation. Mm-hmm. But really who I would encourage to see the perinatal psychiatrist is someone who has a history of mental illness. So, for example, severe anxiety disorders, OCD, mood disorders, and that encompasses both depression and then bipolar disorder, as well as psychotic disorders such as schizophrenia or schizoaffective disorder. I think people don't realize if you have a history and you're stable on a medication and you're wanting to conceive, we've always been terrified in the medical community and super cautious with recommending women stay on medications. And when it came to mental health, what we were seeing was people like psychiatrists, OBs, general practitioners were recommending women to come off of all of their medications. And we were seeing that with coming off of the medications, in some cases, the worst thing you can do, because that can greatly destabilize. I would say that anybody who has a history of mental illness, anybody who's on a medication and wants to know if they should stop it, anybody who's on, and when I say a medication, I mean like a mental health medication. It's okay to find out you're pregnant and be on a medication. The absolute worst thing you can do is stop it, or stop it cold turkey. Go get a professional opinion. And is the right answer always you need to stay on your medication? No, absolutely not. But that's kind of my target audience and who I would recommend come in. Another one too is women who are struggling with, or birthing people who are struggling with infertility. They go to their infertility appointments and will be told, oh man, you are going to have a lower chance of getting pregnant if you are on certain psychiatric medications, and they just say stop everything. And the reality there is that not being emotionally ready, being emotionally stressed, and not mentally well also interferes with the ability to conceive. So it's just saying that the safest thing for a woman and baby's health trying to conceive through pregnancy and postpartum, saying that the safest thing is to just be off of all medications is absolutely untrue with the data we currently have.
This is really interesting, and I'd love to unpack this now since it came up. So a few questions here. Is it ever the case that someone may have had undiagnosed mental health challenges, and then this is something that they realize during pregnancy? And if that is the case, is it because something is exacerbated during pregnancy, or is it kind of just a coincidence? Like, that's something I'm curious about.
Yeah, that is a great question. So another reason why this has become such a forefront of mental health, the changes that we experience with menstruation, becoming pregnant, and the postpartum period, as well as perimenopause, they are what I would say they are vulnerable times for the central nervous system, which includes the brain. So estrogen is protective of our brain. And so when we have fluctuations in estrogen and progesterone, such as during pregnancy and postpartum, our brain is more vulnerable to having developing, I would say, mood and anxiety disorders and psychotic disorders, secondary to not only the hormonal fluctuations, but also the stress that comes along, the new stress that comes along with pregnancy. So not sleeping well because you are up peeing, several times a night, or your back hurts, or it's just uncomfortable to have a belly and sleep. That takes a toll. Being tired, having all these extra responsibilities that you still have to do. You still have to go to, for many women and birthing people, they still have to go to work. They still have to take care of other kids. And those stressors all together make this a more risky time for mental illness to present itself.
Got it.
And the postpartum period too, like you have a new baby, the hormones, are fluctuating, and you lose a lot of hormones all at once. Postpartum, but the sleep deprivation is huge during the postpartum period, contributing to mental illness starting.
That's really interesting. And I do want to unpack that more, definitely, because there's so many factors. I mean, there's internal factors, external factors that are all impacting our brains. So it's super interesting. I did just want to touch on the medication piece. So with the staying medicated, if that is suggested by your physician, I feel like there's a lot of conflicting guidance right now about medication during pregnancy. And obviously, we all heard of the Tylenol and things like that. And so, just wondering from your perspective, what you have to say about that. How can you perhaps debunk some of these myths that are kind of going around regarding, medication during pregnancy in general?
Yeah, excellent question. So I will say, do not use Google as your resource. And another thing that is very misleading is the fact that we've had government agencies and people who are supposed to be establishments that are supposed to be basing their claims on solid scientific evidence, such as the FDA. But unfortunately, not even those anymore stick to basing their evidence on good studies. Mm-hmm. So what I would say is that is another reason to go see a reproductive psychiatrist, is because there are a lot of top scientists in this area and doctors and therapists who have dedicated their life to sifting through the studies that we have that were actually good studies. So, for example, the FDA earlier this year came out and said that there was a link between SSRI use, which is an antidepressant. It's the most commonly used antidepressant. A link between mother taking that during pregnancy and the fetus or infant developing autism, which is completely false. If you were to Google, there are studies that claim that, but you take apart the study and realize that they could not isolate that the antidepressant was the sole cause. There were so many other things going on. Often in these papers, moms were using alcohol or drugs, or, there was maybe they weren't getting good sleep. Maybe they had untreated mental illness.
Right.
Unfortunately, a lot of what you see in the media is just false because of people basing it off of bad studies. The other thing I would say with the Tylenol, there's absolutely no risk of autism in Tylenol use in pregnancy. It's actually the preferred medication for aches and pains during pregnancy. But if autism researchers have kind of come to the conclusion that it's actually the inflammation that's happening in mom's body in utero that they think is linked to autism. So, for example, in the women or birthing people are encouraged to be up to date on their vaccines, because if they contract a certain disease during pregnancy, that can cause a whole host of issues and congenital defects, which is birth defects, mm-hmm. and can cause learning issues within the baby because of the inflammation. You may have heard that vaccines cause autism, but this is the same idea behind that. It's not that the vaccine did it. It's that mom's immune response to the vaccine may have been more robust than someone else. It's all based, it just is not true that it's a general statement. It all is based on different factors, but we think the core cause is inflammation. And who's taking Tylenol during pregnancy? Usually moms who are not feeling good. They've got a viral illness, or they've got a headache or some kind of inflammation. So, there's a lot of misinformation out there. I would say there are trusted sources to look at for women's mental health, I would say and perinatal mental health would be the International Society of Reproductive Psychiatry. They are a really good source. Postpartum Support International is a great source. Mother to Baby, I love that website because it is an organization that has taken all of the decent studies that we've got and evidence and case reports, and they've compiled it all into these fact sheets that are easy to read. You don't have to sift through the data and see, is this a good study? Mm-hmm. They'll say, what do we know about taking this medication during pregnancy? What about infertility rates with this medication? So those in Massachusetts General Hospital has a women's website and a whole women's mental health department that has good resources.
Great. So right down the street for me. Amazing. That I think was such a good way to concisely explain what all of us are wondering. And I think a lot of people who don't have, probably medium to deep understanding of statistics don't realize that you can really manipulate numbers to look however you kind of want. And I think there are biases going into studies, and if you are trying to prove a certain outcome, the reality is at times you will see the numbers the way you want to see them. So I love the fact sheet. I think that's amazing, and I definitely want to take a look at that as well. So thank you for breaking that down for us. So now I kind of want to get more into the brain, because this is something I honestly learned recently. I didn't think hard about it. And I think this is something new that's coming up in women's health, just like from a wellness perspective, is understanding your body, your mental health, perhaps your diet, like all these things that you could be doing throughout your cycle. So with respect to the brain specifically, you mentioned, the woman's brain through the hormonal cycle. So does that mean that, I mean, not to put it so simply, but does that mean that a man's brain just isn't really going through many changes at all, like through time? Or, I mean, what does that
I
look
would
like?
say they don't have the same vulnerability. Their brain is not, their brains are a little more, I don't want to say protected, but because our hormones fluctuate on a 28-day cycle, and I think a man's hormones are like a 24-hour or something, they just don't have as many opportunities for the brain to, I would say, be in a more vulnerable state. Having said that, though, what's very interesting is that estrogen is protective, and so men are at higher risk of getting some of the more serious mental illnesses like bipolar disorder and schizophrenia. So what we know about both of those illnesses are that you have to be genetically predisposed. So it means that you have had, your genetic makeup is already going to say you're going to have either a psychotic break, or you're going to and start hallucinating, or becoming very paranoid, get delusions, or you're going to experience deep depression with some what we call manic episodes. Essentially, when we see people have their break is in their 20s because of stress. That's when the first time people go off on their own and they go to college and they have to, support themselves. And it's the most stressful time in, I would say, after leaving the parents' house, generally is. So that's when a lot of times, because of that stress, that's when people have a mental break. But women have their mental breaks if they are predisposed to having severe mental illness. They'll have those breaks a little bit later because estrogen's protective. Also, sometimes they won't have their first manic or psychotic episode until they are in menopause. Once their estrogen stops being produced.
Interesting.
So I would say it's both a blessing and a curse. Having, the hormones that we do protect us in a lot of ways. But because they are high at some parts of the month and then they go low at some parts of the month, that makes us more susceptible than a man's brain. So I wouldn't necessarily say it's that their brains are different structurally. It's more their brains are not experiencing all of the stressors that ours are.
That's really interesting. And I'm wondering now, this might be a very basic question, but I honestly don't know. So is estrogen highest at ovulation, or what is the cycle like, I guess?
Yeah, that's a really good question. So during the menstrual cycle, estrogen, we always say estrogen establishes and progesterone protects. Talking about the lining of the uterus that would support the implantation of a zygote, or when the egg meets the sperm. But
Yeah.
at the very beginning, but it kind of fluctuates for between different people, but around an average of the first 14 days of your cycle, estrogen's higher. And it is because it's causing your uterus to prepare for implantation. And then around day 14 is when the egg is actually released from the ovary. And the egg in the ovary leaves behind a little shell of itself, and that little shell starts producing progesterone. And what the progesterone does is that it keeps that uterine lining, that nice thick uterine lining for implantation, it keeps it there for 14 days. And then if the no fertilization happens, that is when that little shell that's producing the progesterone, it times out around 14 days, and then that's when the period happens. And then it restarts itself all over.
Okay, great. Super interesting. That's a very good, I think, basis for us to have now going into the rest of the conversation. But that is definitely something maybe to pay more attention to, or just to understand. I feel like we don't really think, I mean, just like the average person like me, I'm not really thinking about this on a regular basis, but it's really cool to kind of know and understand. And then now I kind of want to shift more into, I kind of want to go in reverse. I want to talk about postpartum before pregnancy. But first, just wanted to ask, how common is postpartum depression? You mentioned that's a fear for some people. Just want to get a sense of, we kind of know now, more likely for people who are genetically predisposed. Wondering, how common is it actually?
So postpartum, I will have women come to my clinic and say, oh, I had such bad postpartum with my last kid, or I'm really scared about postpartum. And what they're generally referring to is depression. There can be an exacerbation of anxiety, or I do see OCD as well. And then there's postpartum psychosis. So for the risk of developing postpartum depression and high anxiety is usually like 1 in 8 women will develop it. And I've also seen from like 6 to 20% of women will develop it. What increases your risk is, do you have a history of depression outside of being pregnant? So have you had major depressive episodes in the past? And also, if you have premenstrual dysphoric disorder, meaning that you have severe depression, irritability symptoms. Think of like PMS, premenstrual syndrome. Think of that like times a million, just so magnified during the luteal phase. I don't know if I used that word earlier, but when progesterone's high. If you are super sensitive to mood changes during that time of your cycle, that increases your risk of postpartum depression. But the highest predictor of whether or not someone's going to develop postpartum depression is if they have depression during their pregnancy that doesn't get treated. And that is where a lot of my focus on talking to people is about, is, hey, we can approach this in different ways, but I'm really worried that if we don't, seek treatment for this while you're pregnant, that things will get worse postpartum. And the other thing I would say with postpartum psychosis, it's extremely rare. It's like 1 or 2 out of every 1,000 women who give birth will develop it. It's generally brought on by just the stress of birth, plus the lack of sleep that comes within the first few
Right.
days. The most vulnerable period of time is like 4 to 6 weeks after birth. And the people who are at most risk for developing postpartum psychosis is those with bipolar disorder. So
Okay.
sometimes people know they have bipolar disorder. It's actually discouraged to just continue in someone who's stable on a medication in pregnancy. It's actually discouraged to stop their medication during pregnancy. You can prepare before, but if they're stable and they're like, 12 weeks pregnant, if you stop that medication, they can really, really become sick, and then they are at more risk for postpartum psychosis. So those are kind of the facts regarding the big things I see. I feel like women also want to know, is everybody at risk of getting postpartum psychosis? And
Yeah. Can
it's
you just
so rare.
define psychosis real quick?
Oh yeah. So
Yeah.
psychosis, what
No
psychosis
worries.
is it is misinterpreting reality. So
Okay.
it is when some people will hear voices or will hear sounds where like I've had people tell me that they heard like a telephone ringing, or they've heard voices commanding them to kill themselves or their baby, or just these really intense, it's either hallucinations or it's delusions, and delusions mean a fixed false belief. So that would be like all of a sudden you think that God is telling you that you need to protect yourself and your baby from some outside force. And a lot of times
Okay.
that idea, it's totally not like who they are in like normally, but those
Hmm.
ideas are a lot of times where you'll see a mom who killed her children or a mom who killed her baby. It's generally because of postpartum psychosis. But yeah,
Okay.
that's what psychosis means, just misinterpreting reality.
Yeah.
And for the general population, it's so rare.
Okay. Well, that is great to hear that it is rare. But like you mentioned, I mean, obviously getting the support you need is really important too. So that's
Getting
definitely
sleep.
sleep. I
Getting
know
sleep
that's
is the
such a
biggest.
big. It's interesting that you're mentioning sleep so often because it's just a known fact that your sleep gets worse when you have a newborn baby. And so it's kind of, I mean, yeah, it's hard to do everything. It's hard to think about sleeping, taking care of a newborn. I mean, is there anything you suggest for women needing to get sleep or how they can manage this?
Yeah, so this is a big discussion that we have. Is society has placed this idea on what being a mother and taking care of a newborn should look like, and breastfeeding, that we
Hmm.
should be able to, our body should be able to provide the nutrients for our baby, and it should go smoothly, and there should be no hiccups with it, and we should love it, and it should help us bond. And that having a mothering instinct it'll just come naturally. And neither of those could be further from the truth. Breastfeeding is hard. Caring
Hmm.
for a new baby is hard, and it's tiring. And um, we have to talk about like a lot of time. Oh, I mean, I have this conversation frequently, but that it's okay to not breastfeed if you don't like it. It's okay to pump only. It's
Hmm.
okay to supplement with formula. It's okay to do formula all on its own. It doesn't mean you're a bad parent. It's not reflective of like you being deficient in some way. But what's absolutely necessary is, I love it when dads come into the appointments because, or other moms, the partner comes
Hmm.
into the appointments, because I will say she absolutely needs sleep. It is critical. I said, it's going to be imperative for her mental health that you guys take turns with feeds at night, whether it's pumped milk from earlier in the day that you have in a bottle, or it's formula feeds only at night. But it is crucial for night feedings to be a team effort. Day feedings too, if possible, but if, dad's at work. But yeah, I think that this shameful idea that's out there with, if you can't breastfeed or you don't enjoy breastfeeding, that you're a failure, is such a false narrative. It really, really, I think it adds to depression sometimes. And yes, the biggest thing women can do is get good sleep. And even if they are getting a couple hours, make sure that sleep time is protected, it's restful, and that you've got help. Physical activity is often neglected, but it's so important. Go for a walk with your baby in the stroller during the day. Like, get some physical activity. Make sure you're getting, nutritious foods. It really is a whole whole lifestyle.
So what I'm hearing is, don't be afraid to ask for help. Get sleep. And just because you're taking care of another human doesn't mean you can stop taking care of yourself, essentially.
Absolutely.
Well, thank you so much for validating that. And I think it is so easy to get, I wouldn't know personally, but it feels like it would be so easy to get very wrapped up into it and forget about yourself, just as any person who's taking care of another can be. And so I loved your advice of like, take a walk, go outside. I've heard so many stories of people feeling trapped at home. And so it's good to hear, that advice from you. I do want to go back to the brain again. So you mentioned to me previously that the brain does not want to be depressed. So the brain is going to try to fight depression. I want to get into what is actually happening in the brain when you're depressed, but also how does your brain try to fight it? And what does that look like? Why does it, not fully why is it not fully able to kind of resist it, like maybe your immune system is able to resist a virus or something?
Yeah. Okay. So I would say, first of all, we have to kind of define what is depression at its core versus, what is just being sad. So major depressive disorder at its core is just a slow down and I would say without using the word depressed, but yeah, it's like your brain is just not working optimally with being able to think, regulate emotions, regulate your sleep. Some of the major symptoms I would say that come with your brain just kind of going into this almost hibernation state, trying to protect itself, are insomnia. Sometimes it's insomnia, but sometimes it's sleeping way too much. Fatigue, difficulty concentrating and focusing, having less of an appetite. Some people are opposite. Some people will have more of an appetite. And they're having like passive death wish or suicidal thoughts. The other thing I think that's like a big key indicator is not enjoying things the way that you used to. So just kind of an absence of joy, which we call anhedonia. Those are the symptoms of depression. They can happen in different ways. We don't know the exact mechanism that causes depression, but there is a theory that there is an inflammation response behind it. There's just an area of your brain that is just not as active during that time. And then the chemical imbalance idea that we thought in the past was just like, oh, some people have a chemical imbalance. We don't really think that now. It's more of an injury to the brain, just from stress, from not getting enough rest, having a genetic predisposition, meaning like you have a family history of depression. Everything that your brain regulates slows down. We know a lot of the risk factors. We don't exactly know the cause.
Okay.
What we do, I mean, there are a bunch of different treatments. So, for
Yeah, I was gonna
example,
ask.
the difference between, I would say, the difference between that and sadness would be, and even that and baby blues. I feel like this is a really good point,
Mhm.
is that 2 weeks after you give birth, there's all of your hormones that we talked about. You have so much more during pregnancy. A lot of times people feel great during pregnancy because of this. It's stored in an organ called the placenta that
Mhm.
nourishes your baby. And so at the time of birth, all of those hormones that it was supplying you with just abruptly decrease. So for 2 weeks, there's a lot of your hormones are trying to balance themselves out. It's actually longer than 2 weeks that it happens, but trying to balance themselves out. And a lot of times, people will just say, "I'm crying for no reason. I'll cry at the drop of a hat," or "I'm just sad," or "I'm." It's a lot of just like big emotions as those hormones are trying to level back out. That is different than postpartum depression. Back to treatments, though, it's important to know that medication is not the answer, the only answer for depression. There are a bunch of different treatment modalities based on person's past response, their history with mental health, how severe their depression is. So generally for mild to moderate depression, we'll recommend therapy and lifestyle changes, getting sleep, cognitive behavioral therapy, making sure you're getting that physical activity and you're eating well. And then in some cases of moderate to severe is when we'll recommend both psychotherapy and a medication to help.
The baby blues is a really good point because I could see people maybe entering a panic and thinking, oh, maybe I am depressed. So that understanding, I had no idea the hormone, like the very abrupt hormonal change that you go through right away. And I think you mentioned there could be positive changes to the brain in those 2 weeks too. Is that right? Or are there any kind of like positive outcomes from hormonal influences or changes in the brain after giving birth?
You have a release of the hormone oxytocin, which it helps with bonding with baby. That occurs after birth.
This was something that I was very curious about because we mentioned, maybe not everyone is going to a psychiatrist right away when they get pregnant. That's probably not the first thought in a lot of people's minds. But is your OBGYN, are they ever talking about mental health in the regular checkups throughout pregnancy?
Yes.
Okay.
And you know what? I'm going to bring up kind of why maternal mental health is such a big deal, and then how we're working as a medical community to try to in the OBGYN office, even in pediatrics offices, to try to make sure that we catch it before it's too late. I think like the mid to early 2000s, like 2010 maybe, state started doing what was called a maternal mortality review board. What that was it was a documents from the coroner's office and all of the death certificates and things of they would look at women during pregnancy and up to a year postpartum and what caused their death. And what they were seeing was the number one cause was either suicide or overdose on either substances or mental health medications.
Oh,
And so
wow.
that became a huge focus. And we were like, why is all this happening? Well, so that is when we started looking back at, looking at how can we prevent this from happening. So one way that we do this is by we increased the screening for postpartum depression. So I think in the OBGYNs do it like once pre-pregnancy, once during pregnancy, and then once postpartum.
Okay.
And then the pediatricians will have mom do a screening once, I think at their first postpartum check or not postpartum check, but their first like newborn visit with the pediatrician. And then psychiatrists, I don't know, I just do it generally in my initial visit with them, and then I will do it to kind of monitor how our treatment plan's going. Are they getting better scores? But yes, OBGYN do have screenings in place and can kind of pick up on if you're struggling during your pregnancy and there's something they think that you can get some relief from seeing a mental health provider. OBGYNs are aware of that, and they are, I would say that is part of the normal visit during pregnancy at some point.
Okay, so that's good to know that basically any doctor that you're seeing throughout pregnancy can be a resource, and
Yes.
likely your OBGYN will be asking these questions as well. And it's nice to hear that there's more of a focus on this now too, which is great. And then moving on to pregnancy, can multiple pregnancies make symptoms get exacerbated, or can your mental health experience from one pregnancy be very different to that of another?
Yes.
Okay.
So having postpartum depression with a prior pregnancy also increases your risk. I don't know if I said that, for having it a second time. I will say I've had people who have, and when we say increases the risk, it doesn't mean it's going to happen every time, but yes. So if you've had it in the past, I think it's important to go speak with a mental health provider who can help prepare you for this pregnancy and the postpartum period, because in some situations it may be helpful to have a medication on board. Like if you're doing good during pregnancy and there was a medication that helped you before, sometimes you can restart that in the third trimester. Sometimes you can start it during pregnancy. If you were on a medication already, like an antidepressant, talk with a reproductive or a perinatal psychiatrist, see if it's okay to stay on it. A lot of times, if you have a good support team and have a physician that is knowledgeable in this area, you can prevent postpartum episodes in the future. And so that's why, like, people will come in with horror stories of their prior pregnancies, and we work together to make sure that this is a different experience, because they'll say, or I'll see someone postpartum and they're like, I never want to have a kid again because of what I went through. And I tell them, it doesn't mean that every experience is going to be like that. We can do a bunch of things to help prevent that.
That makes a lot of sense and generates a lot of hope. And you did mention to me, I kind of want you to talk about this, like, treatment is successful. Like, you've seen a lot of success with treatment, and you've seen relatively quick success. It's not years and years of having to rebuild to your health. You've mentioned it can be a matter of a few months, right?
I think you had mentioned that you saw that postpartum depression can last for 6 years. I would say purely postpartum depression, what we would call major depressive disorder with peripartum onset, just means that there's a hormonal component. There are newer medications out there that treat postpartum depression specifically. One is called zuranolone, or Zurzuvae is the brand name. It's a neurosteroid, meaning that it's a hormone that acts directly on your brain cells. If you had pre-existing depression and it just was still there during postpartum, this may not work for you, because it may mean that you had a depression that just got worse with all of the stressors that come with being postpartum. But it doesn't work for everyone. It works for a specific audience. That doesn't mean that relief is not available for you. There are a lot of different things like therapy, antidepressant medications, mood stabilizers, just depending on, your specific diagnosis, the lifestyle changes, like we talked about, getting good sleep, all of those things. I do see people get better. You have to work together, but I do see people start feeling better before, I would say I've seen people within a couple months.
Okay.
So any postpartum depression that's been going on 6 years, I think was just probably a depression that there wasn't a good, a solid support system there to help try different things and get that person, because ideally you should get depression in remission, meaning no symptoms, definitely under a year,
Okay.
with 3 to 6 months for sure.
Yeah.
Sometimes it takes a little time, but no one should be going with 6 years of postpartum depression. So if you develop that, I don't want women to think, oh my God, this is a death sentence. This is like
Right.
what I'm facing. No, go get help. Help is out there. And another thing I want to say is, if the first treatment plan you decide on with your doctor doesn't work, try the next one they suggest. There's like an algorithm and a reason that we start with one treatment, then we'll go to maybe a next. There is very much likely a treatment plan out there for you, and just don't give up hope. It can be tedious sometimes, but it's worth it in the end to kind of stick through it and work with your doctor.
Yeah, I really wanted to have that conversation with you because, like you mentioned, I do want women to have hope, even if they are diagnosed with postpartum depression. And also, it's sounding like we'll talk about this a little bit later, but based on what I was hearing about your practice and just that this field of medicine in general, like we do actually have a pretty good understanding of postpartum mental health now, and there is a focus on it, and we understand treatments. And so I think there's a lot of aspects of women's health that a lot of people feel like is up in the air, or is usually not diagnosed quickly, or it's tough to get a diagnosis and hard to understand what there is to treat them. But with this conversation I'm having with you, it sounds like there's known success stories. We have a good understanding. We know how to diagnose it pretty well. And so I just wanted people to kind of understand that if you're getting the help, um, there's very promising outcomes. So we talked about your brain on the hormonal cycle when you are not pregnant, prior to being pregnant. What about now? And we also talked about it a little bit postpartum. So now what about while you are pregnant? What changes is your brain seeing? Because the hormonal cycle is different while you're pregnant too. So what does that look like now?
So you're not going to have the fluctuation, which leaves your brain vulnerable. But I will say sometimes the stressors that come along with pregnancy, I think sometimes birthing people are a little more sensitive to just having more estrogen and progesterone and hormones on board. But really, I don't see that much develop during the period. Usually what I'll see is existing depression or existing anxiety get worse during pregnancy, because there's an extra stressor on top of it, or you're not getting good sleep, or just there's a lot of different variables. But I would say the bulk of the mental mood and anxiety disorders being, as far as being linked to hormones, the bulk of what I see is postpartum with that big change.
Yeah,
or the big drop off of hormones. Yeah.
Okay. That because your hormones are a little bit more stable during pregnancy, it's a little bit less.
People will say they feel excellent during pregnancy because
cool,
you
great.
don't get those fluctuations. Yeah. Everything's
Okay.
stable. They're like, I enjoyed it. I was so happy. I like, I don't know. Yeah.
Yeah. Interesting. Yeah. That's really cool to know. One more thing about while you're pregnant. So we kind of talked about impacts of inflammation or immune responses or things like that on the fetus or the baby. If you have a mental illness and, for instance, you suggest that someone take medication during their pregnancy and they for some reason decide not to, does that impact the baby at all, or
Oh,
is that
absolutely.
okay?
Yes. And that is I would say not the mainstay, but that is a bulk of what I do is I have these, what we call risk versus risk conversations. So I talk a lot, but a little bit of the backstory is we come up with our guidelines for how we treat things, mostly based on case reports in the past, or in the medical community. The gold standard is to have data that supports a treatment from a randomized control trial, right? Which means we have half people getting a medication or treatment and half the people receiving no treatment, and we compare them against each other. And then that's our data. You can't really
Mm-hmm.
do that with pregnant women because it's unethical to be like, hi, we know
Right.
you're pregnant, but like try this and see how does it mess your baby up? Does it mess
Of
you up?
course.
Like what? So what we've done is when people were saying, oh, completely go off your mental health medications, and we were seeing women have a relapse, what we would call it, of their mood or anxiety or psychotic disorder. Relapse just means they're not at a stable place. They're struggling again. We were able to gather data that shows, and by we, I mean the reproductive psychiatry community was able to gather data that consistently showed that this increased the risk for poor outcomes for the pregnancy and mom. So
Oh, wow.
untreated mental illness during pregnancy has been linked to giving birth earlier than, so what we call preterm birth, before you're supposed to, going into labor before you're supposed to, having a baby that's smaller, not growing as fast as it
Mm-hmm.
should be. We call that small for gestational age. Increased chance of having what we call preeclampsia, which is a high blood pressure, and it puts you at risk for having a seizure. And the only treatment for that is to deliver your baby early. NICU stays, so increased chance of baby having complications and having to go to the neonatal intensive care unit. And then the biggest one was if you go untreated, if you have an exacerbation during pregnancy that doesn't get treated, then you risk having the severity of the mood, anxiety, psychotic disorder become more intense and worsen during the postpartum period. So that is, I talk to people about that risk, right?
Mm-hmm.
Whether or not, what we have to gauge is we have a conversation of, is where you're at right now putting you at risk of having those things?
Right.
And if it's determined yes, are they having like a mild episode that would respond to therapy? Great. Go. Some people I say, I really don't think, I think you could do this with therapy alone. It's therapy and
Mm-hmm.
lifestyle change, and we don't recommend a medication. But for more moderate to severe during pregnancy, a lot of times we will discuss medications. And now, where does that data come from? Well, there were people who decided they wanted to stay on their mental health medications. And what we've done is we've been able to look back at those pregnancies and see what were the outcomes.
Mm-hmm.
And, with antidepressants, there hasn't been shown to be the same outcomes as there are with untreated anxiety, mood, psychotic disorders. In fact, we were talking earlier about the FDA saying that SSRIs are linked with autism, which is not true. We've not been
Mm-hmm.
able to replicate that. But what has been linked to autism is untreated mental illness, um,
Okay.
and neurodevelopmental disorders, poor bonding with baby.
Mm.
Um, yeah, and so there really are only a handful of medications that we know cause birth defects.
Okay.
And so we talk about the risks of starting the medication that would be helpful for them. It's generally advised to if they need a medication, to be on one that's been helpful in the past. That lowers baby's risk and mom's risk for the poor outcomes all across the board. The name of the game kind of is what works for you. Let's get it on board. Let's treat your symptoms to where you're not having any. we would say treat to remission, where you're not having any symptoms anymore. And that is what's going to be safest for mom and baby. Misconception is that moms will say, oh, well, it's working, but I'm on a really low dose. And they're still really depressed. And they're like, I don't want to increase the dose because I want to decrease the baby's exposure. But that's actually the worst thing you can do, because baby's not only being exposed to the medication, but also the illness at the same time.
Right.
So the risk factors for complications go up higher. Generally, if a medication's indicated, use it to the dose that's going to make you feel better. And that's going to be the best.
Okay. Thank you so much for sharing that, because I think a lot of people are trying to think about prioritizing the baby. But again, it's this concept of help yourself so you can help your baby, your health, everybody's health. So that's really interesting to know. And I think a lot of people have been thinking about that lately. So thank you so much for sharing that. And now I want to talk a little bit about your practice, because you are one of the few perinatal psychiatrists in Oklahoma City. So want to ask, what was the start of your practice like? Why did you decide to locate there?
Yeah. So I would say this type of psychiatric practice has traditionally been more advanced, more established on the coasts and bigger cities. But the middle of the country and smaller, like rural areas or rural states, in general, tends to be a little bit behind on that. And so what we were seeing, and I'm from Missouri, and I was exposed to this area and really, really loved it. This area of practice in psychiatry during residency. I got certified. I did a bunch of extra training and rotations in this. And I was approached, as I was looking for jobs, I was approached by one company I was looking for a job within, and they knew kind of what I wanted to do. And they said, oh, there is a severe need for this in the state of Oklahoma. The maternal mortality rates in Oklahoma have been some of the worst in the country. And so we wanted to work and fix that. So I relocated, and there was already a really big presence of women's mental health in general here, but we wanted to focus where there wasn't a big presence, was just one place where we can fully focus on the mental health during pregnancy and the postpartum period, rather than women's mental health in general, just targeted focus. And what's been really, really great is that I've gotten so many referrals and gotten to work really closely with the midwives and OBGYNs and primary care doctors who were like we talked about earlier, they'll get those depression screenings and they're like, we never knew what we were supposed to do. And now they have an outlet and a way to, get those people help. And I would say my favorite part, though, is that we've been able to get access to to the rural parts of Oklahoma, where there's no access to mental health at all, let alone perinatal mental health. So it's been excellent. It's been great. Do a lot of telemedicine visits, and I would love to have a therapist in my office. We're working on getting a therapist hired. So if anybody has experience with therapy and wants to relocate to Oklahoma City, give me a shout. But we've only been open for a couple of, let's say, since August. So it's still pretty new. But it's been really, really rewarding. I've really liked it. Another thing that I think is worth mentioning too is that perinatal psychiatry also incorporates like grief and loss. And so I would say, because I get referred everybody, I don't think that this is common like in every pregnancy, but I just get referred the ones that are struggling. But I've seen, unfortunate cases of intrauterine fetal demise, which is a baby dying and, not making it either at the time of birth or before. And that's that's such a weird spot for a woman to be in, because they feel like there's absolutely no one that understands them. They go through this traumatic event in the hospital, and it's like, okay, go home and heal. And they're like, yeah, how am I supposed to heal from that? There's a lot of trauma involved in this. It's been nice knowing that there is at least a little bit of an outlet for those cases and those people to come and get some kind of, relief or direction, or just support.
Mm-hmm. And being in an area that doesn't have as many resources, how do you, make yourself as so accessible to people? And then also, what advice do you have for people who are maybe living in a more rural area who need these resources?
Postpartum Support International.com. They are a national organization that have resources. They have volunteers that will connect you with resources. There are free support groups that are essentially categorized by any kind of situation you may have experienced during pregnancy and postpartum. And you can get on there and you can meet people who've experienced the same thing, and just kind of feel like you have someone that understands you. They have a directory on their website that shows who practices, either both therapists and prescribers, who practices in this specific area in your state. And then I would also say too, there's a network, most states, not all states. Oklahoma is working on getting one up and running, but there's also maternal mental health access lines. Essentially, most states have an organization where your primary care doctor or your OBGYN, if they are caring for you and you have a mental health issue and they don't have anywhere to refer you, they can call into these organizations and get essentially free medical guidance from a reproductive psychiatrist on what they would do. So access is out there. Postpartum Support International, the look on that website. Second, Lifeline for Moms, I think is what it's called. Lifeline for Moms should show like the network of those free, those helplines that your doctor can use to get advice to help you. And so find out the number to the one for your state and bring it to your doctor and say, hey, I'm struggling with this and I know you can't get me somewhere, but would you be willing to reach out to this and get a consult? So I think it's important that we spread the knowledge of the resources that are out there and that are free.
Yeah,
because
definitely.
yeah. And we're really, really just not but there's a need, and it's trying to be met by a lot of good people, good doctors in the state. And there's just getting the word out there, I think, has been the hardest part. So there are programs that exist. It's just getting the word out there that they are there and they're available in certain states.
Definitely. And that's what I'm hoping the website can try to facilitate, the sort of conversation, share resources that worked for people. Yes. Also, I'm going to link a bunch of the resources you mentioned in this episode, but I think it's super important to be having conversations about the organizations that exist and resources that are accessible to everybody. And I think just by talking to people who have had similar experiences to you or who have experienced something prior to you is super important. And it's something that's not common in women's health. And so that's sort of what we're trying to facilitate here. But I totally agree. I think, spreading the word is super important. I also think in the US, we don't think of us having a lot of resources for health because we think, oh, our health isn't socialized. So we don't have access to a lot of free things. But if you look, there are organizations, there are,
That's such a great point. This service is not available at every hospital necessarily, or within every health system, or like where we would think there's a way to, can you get a referral? That's where I think our health care system's lacking, is like the centralized support. But absolutely, those resources are out there because of government funding, and people have used it and put it to good use for, maternal mental health.
And your practice accepts Medicaid too, right?
Yes. And so my practice is in Oklahoma City, and we accept, I think, most insurances. So if you're in the state of Oklahoma and you are pregnant or you are postpartum and you're struggling, ask for a referral. You just Google me, Kalee Woody, have your primary care or your OBGYN send a referral, and I can see you via telehealth or in person.
Well, thank you so much. And thank you so much for all the important work that you're doing and for spreading the word. I learned so much just in this conversation, and obviously just talking to you prior, but I can tell that you are really passionate and advocating for women, and that's exactly who we need right now. And so I just really want to thank you for all the work you've put in just to even get to this point, and then now all the work that you're doing. Really appreciate it, and thank you for taking some time to talk to us today.
Yeah, thank you so much for inviting me. This has been really fun. I think it's so cool what you're doing. I feel like a lot of the information that's out there regarding women's mental health honestly is there for like other doctors or medical students or residents to learn from and be like, "Oh, I can do that," or "Oh, this is someone we can collaborate with." I don't know a whole lot of resources that are like, "Hey, half of our population, this is what's out there," and like having a conversation about what's available for people to use as a resource. So thank you so much. Thank you for what you're doing. This is great.
Thank
Yeah,
you.
I've
Thanks
had a
for
blast.
supporting. Awesome. Well, I will let you go. But again, thank you so much. Hi, everyone. Thank you for joining us on today's episode of the Unison Community Podcast. As a reminder, the information shared in this podcast is for informational and educational purposes only and is not intended as medical advice. This content is not a substitute for professional or medical diagnosis, treatment, or advice. Always seek the guidance of your physician or other qualified healthcare provider with any questions that you may have regarding your health or medical condition. Never disregard professional medical advice or delay seeking it because of something you heard on this podcast or read on the website. Thank you again for being a part of our community, and we hope to hear from you soon. Does your organization support women's health, empower women to better advocate for themselves, or to understand their bodies? Please reach out. We'd love to hear from you, whether for sponsorship, partnership, or just to connect.